All right, we will get started. Hello, everyone, and welcome to what is the fourth in our series of 10 webinars that the Oregon Office of Rural Health is hosting on critical access hospital finance and operations. Today's webinar is Ensuring Long-Term Success Today, 2023 Revenue Cycle Strategies. I'm Sarah Anderson. I'm the Director of Field Services at the Oregon Office of Rural Health, and here with me today also is Stacy Rothwell, who is the Program Manager for our office focused on quality improvement. Next slide, please, Carrie. So before we get started, I want to go over a few logistics. The audio has been muted and the video is turned off for all attendees. You can select the ellipses on the right-hand side of your screen to populate the chat feature, and it's on the bottom. Please use that chat feature to ask your question, and we will monitor chat for questions as we go along and ask them of our presenter at the end. You may also raise your hand by clicking on the hand icon at the bottom of the screen, and then we can unmute you so that you can ask your question live. The presentation slides and recording will be posted shortly after the session, no later than tomorrow, on ORH's website at the link on the slide, and I'll put that link in the chat in just a moment. Okay, and then, sorry, lost my place there. So, as I mentioned a few moments ago, this is the fourth in a series of 10 webinars that we're hosting with a focus on COF finance and operations. And you'll see, oh, Carrie, if you can move the slide deck forward, the next 6 webinars listed on this slide. You can also find more information on our website with the link that I'm going to add to the chat in just a moment. But first, I am going to introduce our speaker. So with us today is Carrie Bova. Carrie has over 15 years of experience managing revenue cycle operations. She's an expert in optimizing revenue cycle operations and improving cash flow in rural healthcare organizations. She has a proven track record of increasing revenue cycle efficiencies, reducing expenses, establishing compliance, and working toward developing growth strategies in a constantly evolving industry. Prior to joining Wintergreen, Carrie worked for multiple rural organizations. She was instrumental in successfully turning one hospital that she worked at for over 10 years into a critical access hospital top 100 organization. So I'd like to welcome Carrie. Thank you so much for being here, and we're looking forward to hearing your talk today. And I will turn the floor over to you.
Thank you, Sarah. I appreciate that lovely introduction. As Sarah spoke, my name is Carrie Bova. I'm very passionate about rural healthcare. I have been in revenue cycle operations for approximately 20 years. I am very excited to talk a little bit today about some of the industry standard, but also what is non-standard. So the intent of this presentation is to tell you what you can do in 2023 to strategize and really build a successful revenue generating revenue cycle department. So we're going to talk a little bit about prioritizing retention. Retention is a key concern for healthcare organizations, specifically those in rural America. And that is because we see a influx of retail healthcare. And really with patient consumerism being priority, we want to talk a little bit about how we can work on prioritizing patient retention. We're going to talk a little about identifying current opportunity and aligning with national and state health initiatives, some of the existing opportunities, some of the growth opportunities that don't involve a lot of investment and are things that you could do potentially now. We're also going to speak about revenue optimization and integrity, talking a little bit more about enhancing charge capture, really monitoring payment expectation and variance, and eliminating or limiting risk to the payments that we've already received. So 2023 priorities, industry standard. We've all in revenue cycle been inundated with content really associated with industry trending priorities like inflationary pressures, increased denials, use of AI and data analytics. All of those have great value, but in rural America, they take time to attain and usually take investment. So, the intent again of this presentation is to really focus on some key areas that can help you achieve those priorities and serve as a foundation and a building block to get potentially there at some point. But it really talks about how you can optimize and stabilize now and what you can look at with what you have to optimize in a future state. So, one of the largest initiatives I think all rural health clinics should have, and rural health care organizations, critical access hospitals as well, should prioritize patient retention. Um, and I say this based on multiple factors and multiple visits across the nation to critical access hospitals. And a lot of times there are so many people overtasked or wearing multiple hats that patient perception is not always where we think we should be or what we see ourselves as. So, patient retention should be one of the top priorities in your organization. There's an increasing and growing market of just being able to get on your phone and speak with a doctor and make an appointment. And what we need to do in rural America is develop strategies to kind of have similar offerings to minimize our service costs, which is very difficult because sometimes critical access hospitals and rural healthcare providers pay so much more for goods and services. We're going to enhance the image and reputation of the organization. I think that's a great strategy for patient retention. We all know that being able to get on Teledoc is great, but it's not the same experience we have with these community providers invested in the communities that we serve. So, really looking at how we market our an enhanced image and reputation. We want to have improved quality and financial performance, and we want to just demonstrate that in what we do to our patients. And we would love to have improved patient relations. And this is from the time that someone answers the telephone at your organization to the actual last moment the patient is within the organization. So, really taking a look at how we could evaluate patient costs and payment options. Are we passing too much on as a critical access hospital to our patients? Are we marketable with other organizations in our market share? Do we offer patient financing options uh, or prompt pay discounts and financial counseling? Are we offering underinsured charity? Are we, mitigating patient dissatisfaction by optimizing a pre-registration process and minimizing wait times to actually see our providers or be in our waiting rooms? And then really the perception of our office staff, are they inviting? Are they accommodating? Um, are our practitioners consistent and do our patients trust them? And how do we build those relationships with community provider events and potential activities? And do you offer extended business hours or hours that are available to your public? And that doesn't just mean your clinic, but also your business office. Really creating an environment where finance and clinical are as much shared in the patient experience as they are in the actual organization itself. So, just a little roadmap of a sample, just a few little hints. So, patient intake, that could be from the time the patient calls to schedule an appointment. Patients should receive reminder calls. They should receive financial counseling. They should be screened for charity. You could talk about payment plans and obtain pre-service collection of copay before they even come to your clinic or your organization. I use clinic as an example specifically because it's mostly elective. and it's a common platform for scheduled elective services. But really, are we talking to those patients before they arrive? Are we eliminating wait times with our providers? Are we creating a schedule that is, very flowing and overlapping so patients are seen and talked or seen and accommodated quickly? Pre-appointment telephone experience. I mean, really offering clear and concise directions and expectations to save time. Significantly important with new patients, because you only have one opportunity to make a first and lasting impression. And it tends to have that pre-call tends to eliminate frustration and any uncomfortableness at the window, any conversations that need to be had. Then at check-in, every patient should be greeted and promptly roomed. One thing that is very frustrating in many Press Ganey surveys is that oftentimes patients feel they may sit in a waiting room or waiting outside during COVID or waiting for too long and then no one communicates with them. Utilize your reception staff. And one rule of thumb at one of the organizations I worked with is every 15 minutes, if there's one person or 20 people in the waiting room, walk out, go from behind the desk, check in on everyone, make sure they're okay. Just random acts of patient feeling like their priority is going to really improve the patient retention and the image of your organization. Same thing, little tidbit of information. If your patients have virtual visits and you have a virtual waiting room, definitely you should monitor that as well. I'm not sure if everybody's there yet, but I have, again, just sharing some of the experiences I've been told of. And then checkout. Checkout should always include a summary of visit, and it's your communication on the next appointment. This is where you are gaining that patient retention of one more visit. So having that checkout window, making sure that patients are scheduled at the time of conclusion of one appointment for the next is very important. And if the patients have ancillary orders, really try to encourage patients to use a hospital or parent entity or clinic, vice versa, for those services. Really be your own marketing strategy by word of mouth, and make sure that your patients are well versed on all the services that you do offer. Use checkouts as an enrollment hub for care management or telehealth consent. And one recommendation I do have is do not collect copays, outstanding balances, or, if a patient is in bad debt, attempt to collect bad debts at checkout window. The last impression of your organization or clinic should be everything was taken care of and you're leaving the patient with the impression to come back. Handling the hard questions should be done, pre-appointment. So reception and patient-facing staff are very important in patient retention, really working on building front-end competencies to ensure that all your patient-facing staff are knowledge and courteous. And basically, your front-end staff are your only face-to-face encounter with the patient sometimes, and it's what can make or break you. Front-end staff should be well-trained. They should be able to understand insurance plans and the patient's certificate of coverage and coordination of benefits. I know a lot of folks understand that patient access, patient registration has been significantly challenging on the revenue cycle side. So really investing in that staff, and really making them understand the importance of their role in the organization is very important. Those pre-appointment processes can help to achieve compliance with no surprises. You can have your financial counseling and you're setting your patient expectation. They already know what to expect when they come to your organization. That can tend to really, really make a difference. Then just educate and automate to ensure that patients aren't inconvenienced and they have options. Do you have, an on-call answering service? Can your patients check in or update demographic through their patient portal. Just little options where they can check in or verify appointments through an automated phone system or via text message, really starting to meet patients in that technological age and be as convenient and compete with some of the retail and larger organizations. And then really establish routine intake and checkout processes that really focus on the efficiency, but also the retention and the goal of getting that next appointment, providing the best experience, and really making that patient leave your organization feeling that they had a phenomenal experience. That gets shared in the community. It's free marketing, and we should always strive to be our best. And word of mouth marketing really is great in rural America. Um, One thing, if there is a process post appointment or checkout, and they have ancillary orders, try to set up reminder calls for those as well. I don't know if you could use your care management staff or any nursing staff, but really to make sure that they are following up. 30% of ordered testing from clinicians does not ever get obtained. It's non compliance on the patient end. And just a lot of it is forgetfulness, or the doctor said have the lab test in 6 weeks and nobody ever reminded them to do that. So really incorporating some routines with our reception and um, our staff to do that will help, and it helps the patient feel more cared for. And then really evaluate annual exams, well visits that occurred 366 days ago. If you don't have a full schedule, really start getting those patients engaged and coming into the office for preventative care. And then monitor and track how patients see you, not how we see ourselves. Sometimes it's very eye opening if we have feedback surveys in our clinics, and make them tailored specific to revenue cycle experiences, not just the provider. You want to know how the administrative functions work of your organization and how your patients see those. Um, for 2023, we really need to focus on identifying opportunity and creating a financial viability model. Some ways to do that, and in alignment with national initiatives. The Health and Human Service Department recently released Healthy People 2030. And one of the things that it really is a comprehensive program, but what it focuses on is increasing preventative care for people of all ages, and five key factors: the health disparities, health equity, health literacy, well-being, and the social determinants of health. Unfortunately, in some of the models, rural America really comes below the bar there. But preventative care is so important, and the benefit of a lot of preventative services is there's no out of pocket patient expense. And I many webinars, I really preach the preventative service model, because there is a lot of ancillary revenue to be had. It does not impact your patient's wallet or pocketbook, and you are providing quality and comprehensive services to your patient. Preventative care really has optimal benefits for reduction of risk for diseases, for certain disabilities, um, and in some cases death. But not everybody monitors it, because they're not, I believe very much so, that patients don't realize all the preventative services that are available to them. We know that children need regular well child and dental visits. I don't know how many organizations on the phone are providing fluoride varnish in any of their organizations, or really focusing on the fact that that can now be done in primary care. Really teaching the importance of preventative care to our providers, what services are available, educating our revenue cycle staff on how to bill for those services to receive payment and prevent any risk to the patient. And rural healthcare really has the opportunity to shine here. They have the opportunity to develop a proactive, not reactive approach, and effectively manage patients. I think rural America also gains the most benefit socially and economically if we can really start addressing these disparities and meeting the mark, if not exceeding it. And I think the benefit that rural America has is we all wear multiple hats and we're small, but we're smaller and we're small enough to be able to manage it appropriately if we could just tweak the workflows a little bit. So, talking about these opportunities, evaluate identification of service offerings in your organization that address some of these leading health indicators and kind of make a flow chart or a mental note and align your service delivery with the goals established by the initiative. So, cancer screenings, chronic pain, there's a new code for pain management, diabetes screening. And when I looked at this initially, I thought this screams, let's start using group appointments, group types, and really increasing awareness and quality of care. But tobacco groups for teenagers that speak specifically about vapes, child and adolescent development and depression screenings and early intervention to prevent mental health or substance disorders later. I mean, really, there is no limit to what can be done, and aligning with the initiatives to be where we need to be, I think it's going to now no longer be an option at some point. I think we're just going to have to do it. So, because I'm always focused on proving that these things are feasible, I really want to talk a little bit on this slide just about alignment with those health indicators, but alignment with that whole person care initiative and the benefit it can be to your organization. So, for example, evaluate how you are providing your care now and you're protecting your payments, but what else, how can you expand upon it? So many facilities are not doing in clinics there or in their ancillary departments, they're really not picking up the screenings for obesity or behavioral health counseling, the annual alcohol misuse screening, depression screening, and they're really, if you look at this slide itself, this is a serve my entire organization. So some of these may start in our clinic, some of these may be ancillary ordered services that are going to lead over to our hospital. But all of these are going to lead to a better patient quality care model that you can market and you can celebrate. So really taking some focus, but also I wanted to be very specific to you all in Oregon. I will tell you that I checked multiple, if not all, of some of these codes. They're all payable by both Medicare and Medicaid. So just taking a look at these and identifying how we incorporate those as an opportunity into our existing strategy and plan. And then opportunities for a future state. And again, we're looking at whole patient care as the initiative. So I really want to take a minute and just do some math. If you have 100 Medicare members and 65% of them are enrolled in a care management program, and we now have pain and behavioral health integration codes that are provided by Medicare, because they're really focusing on care management, preventative service delivery, and really managing some of our health disparities. Up to 60,000 annually, we could receive for 65 patients. So if you start looking at your impaneled sizes and using care management opportunity to bill, you get a sustainable monthly revenue generation. And it really is with what you already have. So really focusing on it, and it generally can, if implemented well, pay for itself in the first year. The other really important topic I'd like to talk about opportunity wise is the future state of behavioral health integration. We know that CMS is really pushing, they're promoting behavioral health, wellness, and whole person care. We want everyone to achieve the best health possible. Now we see CMS aligning with HHS, and we know where our industry is trending. So, how do we be ahead of the curve? Proactive instead of reactive. So there are new provisions that add on to allow you to have different provider types providing services, really integrating some behavioral health care coordination and or services in your organization is really somewhere that we should be looking. And as we're looking at these, we should also be identifying how we make these opportunity available um, for revenue operation and integrity. So, um, revenue integrity. Revenue integrity is ensuring that everything that we do is converted into claim, which is converted to payment. It's really important to use systems and procedures that focus on compliance, but also on optimal compensation. And that doesn't mean increasing your charges. It means that you have to manage revenue better, you have to manage your contracts better, and you have to ensure workflows that promote a healthy cash flow environment. So, pricing. Many providers are using that to increase revenue. It should reflect accurate charge to cover expenditures and service delivery, but it's not where you go to increase and enhance revenue without understanding the implications that it has on patients. So, current environment with the economic shortfalls and concerns with people having money in their pocket, this is where we go to those preventative services. This is where we renegotiate contracts and we try to avoid out of pocket costs, but enhance the care we're providing to our communities. We often pass on cost to the patients rather than focus on the contractual and is it cost effective. Charge capture. So, charge capture and CDM management are a way to ensure that all services being performed are being captured and claimed. Often, CDMs aren't well managed, they don't review expired codes. So, take a look at that. There's also a difference with billing staff with the use of CPT rather than HCPC. The first priority I would recommend in revenue integrity is just doing a thorough service review in conjunction with your CDM and have a finance and a department person together to make sure that really everything that they provide in that department is reflected in the CDM and can be charged for. A lot of healthcare records use super bill templates, and those templates are often managed by IT. So maybe there's some changes that need to happen and haven't. So really paying close attention to that can help. I recommend having a multidisciplinary review of service with clinical, finance, and IT because there's so many components to interfacing or multiple EMRs. So really look for that gap analysis and any missed charge opportunity. And we've talked about contracts, but basically identify what you're paid for services and if that aligns with what you need to be paid to continue to provide that service. Service line contribution to the overall margin of the organization really needs to be something that is more granular and identified so we can make smart choices about what services we're providing and if we're providing optimal services to the community. Workflow, really. Many workflows focus on claiming processes, but leave out cash application. Really ensure that your system has a uniform cash application process for reporting remittance codes. Your denials may not be your denial. You may not have the full picture on your denials if you're not using standardized instruments like 835s with standardized adjustment codes. Oftentimes, some people really try to keep it simple and it all gets rolled into a contractual. It's not the best way to identify what you're potentially leaking. So really take a look at those workflows and focus on the cash application workflows. They often bundle denial and contractual adjustments and really shouldn't. We should segregate those and pay closer attention. And then compliance. So failure to comply with payer medical policies or our state regulations, it can lead to compliance concern that result in payment penalties or risk licensures. So, um, really taking extra steps to make sure you're complying with No Surprises Act, that you're complying with the regulations for RHC and things of that nature, because we have to have strong compliance programs to compete as well. Revenue optimization. So, pursuing new revenue opportunities and sources is challenging, I know, but identifying really, is the optimization um, going to result in an improved process, cash flow, and workflow. So, really taking that walk in the shoes with the supervisors and identifying who is doing what in your organization, how that overlaps, should it overlap, is labor distributed fairly? Could people get to denial management or AR if they were able, to do something else? Is there rooms for shifting and working smarter and not harder? So look for investment and or effectiveness of software for auth, eligibility, charge capture, and potentially denials management. Um, So, in an evolving market where we face new challenges and regulatory pressures, being proactive and focusing on industry trends, really strategizing and preparing us for the future, preventing risk, and being, at the forefront of change with reimbursement policies and thought processes is really significantly important, but also identifying that what you're doing in your organization as a priority is going to lead you to a continual state of progression. So, focusing on preventative care is really focusing on quality metrics and focusing on value based payments, and really starting to incorporate these small workflows will help us be ready instead of be reactive. And with that, I will ask if there are any questions. We got through those slides fairly quickly. There's a lot of information in there. I do have a couple of questions for the group if anybody wanted to put in the chat, but is anyone already performing behavioral health integration in their organizations? Um, I'm not sure if anyone is, but if there is someone doing that, I'd be interested to know. How many people have care management programs? What has been your experience with those? And then basically that front end trending. Are you getting in there, and are your front end staffed effectively trained to identify what they need for preventative service eligibility, really communicating and knowing those insurances for your patients, so when they arrive they feel well cared for and that we have subject matter experts there dealing with them. And with that, I will turn it back to Sarah.
Thanks so much, Carrie. Really great presentation and a lot to think about there. We don't have anyone responding in the chat yet, either to your questions or having a question, but I have a couple of questions that came up in my mind and also in Stacy's mind, which are, what are the best strategies to get started? Like I feel like in many ways, incorporating some of these strategies into your operations might feel a little bit overwhelming. And so I'm wondering if you have any best practices or, processes that kind of help with that.
It actually, I'm glad you asked that question, because it can be it seems like a lot of information and it seems very daunting. So similar conversation at a different organization, and they said, this just is all really great stuff, but I don't know where to begin. And I said, how about this? Take next week's Medicare patients, have your front end staff go out and check all the preventative service that they are eligible for. And he, because it had been an impaneled patient, so they did that, and they checked just a few Medicare patients and identified really that it wasn't that hard to identify that. So they then identified, oh, wow, I'll say John Doe is eligible for a low dose cancer screening, and oh, they're due for their annual wellness visit, but they're coming in for a cough. Maybe I can get that scheduled. And it was amazing to me by just starting that conversation and watching it in real time. The organization was the staff were thrilled. They knew where to find it, they knew how to look for it, and then they were communicating it with the nurses, setting up billing alerts, and then generating extra volume in their clinic and volume of ancillary revenues for the hospital. So how we started was just really just pulling one Medicare, 1 week, and picking out some Medicare patients and focusing on their preventative service eligibility. And then we also are logging those patients to track and trend throughout. And 45% of the ancillary orders that were generated for that patient, those patients, in general, have been completed at the parent entity, and the parent entity has received percent of charge ratio on those ancillaries. So now we're tracking the ancillaries that are ordered, the volume of ancillaries ordered per provider to identify the improvement in just that one step and how much money that can generate. So that's how I would recommend. I would do a gap analysis, but I would really start with what are we missing for preventative care? And really start looking at that and developing that communication back to the provider so they're ordering it, because right there you're already evolving and you're taking better care of your patients, and you're generating revenue, and really it's just with an eligibility check. And that is what I suggest everybody to start. You'd be amazed the thoughts and the brainstorming that come from those sessions. And I think that was the best way to start and show the impact and the deliverable and get buy-in from the providers.
Great, thank you. And what you were talking about there and kind of thinking about the next step from there, in terms of care coordination and population health, we're seeing a lot of movement. In fact, our office is doing a community health worker training program, both on our own and in collaboration with another organization. And there's such a role for community health workers in assisting clinics and hospitals in that space.
Right.
And I think that one of the challenges that we've identified and that we've heard from rural healthcare organizations is, they're not really reimbursable by Medicare. It's kind of reimbursable by Medicaid, spotty on the private insurer side.
Hmm.
But if you're looking at it from a return on investment perspective, within the lens of coordinated care or that type of thing, what kind of experience have you seen in other parts of the country where that role is really paying dividends as you're looking at those long-term growth strategies in terms of care coordination?
Oh, care coordination. First of all, it's a myth that it's not reimbursed. Care coordination and care management is reimbursed. It's just, it's that you have to meet the requirements for documentation. I will tell you the most successful clinic that I've seen implement care coordination utilized a vendor to provide the um, service, and they did all of the documentation. It cost the organization $15 per patient, and it generated for a very small practice almost $100,000 more a year just by and the retention rate went up 4% the first year. So I think that what I'm seeing is um, the most successful strategies utilize vendors to help meet the need with the documentation, like a nursing, but they also have used hospital services and labor hospital labor specific to like respiratory therapists or physical therapists to really start bringing those folks into meeting the minutes and the needs. So COPD is a big initiative, having respiratory therapy do SOAP notes, groups, trainings, really working with incentive spirometry with those patients. And they are a qualified health professional that is doing this under the care coordination order to improve the outcome for the patient. It really can be profitable if done well. Most specifically, I would recommend that you really spend some time on the CMS website talking or reading through the initiatives and the new care management models and codes that are billable, because for RHCs, that's $77 for a Medicare member per month, 77 plus, and it's only growing. That is in some instances, that's more than most facilities are receiving for some of their commercial E&M levels. So really investing in that, you can see it generate revenue, but the other benefit is specific to rural healthcare. Again, it really catches on. And I do say this for the elderly population specifically, it really catches on because it's small communities and neighbors and families speak to each other. And it really, it was surprising to me how well it can take off when you start implementing that checkout process and asking if they'd be interested in having someone help. And it's in the scripting, right? Help organize their care, make sure they receive all their preventative services and they're the most healthy they can be. And then people talk about it at church or at community events. And it was quite cute. I was visiting a site at once and they came in and she said, my neighbor told me she's got the nurse calling her once a month talking to her about this, and she wanted to be involved. She didn't know what it was called, but she wanted the same that her neighbor had. So it really can take off by like wildfire, and it really is billable, and it just has to be done and laid out appropriately. So really looking at a care coordination, either vendor or model, is very helpful for the patient population. And I think it's very helpful for where healthcare is trending in the future. And with that, if we don't have any questions, I will advance. I believe Sarah has just a couple slides here.
I do. Thank you for taking that, Carrie. I was on mute, which Stacy just texted me and alerted me to. Yes, we don't have any other questions, and I'm going to go through a couple of announcements. One that I'd like to mention really quickly before you leave is that when you exit, there will be a survey that automatically pops up from WebEx. Please do take that survey because it helps us provide you programming that's responsive to your needs and gives us feedback to help improve our programming going forward. So please don't forget that. And you also have the opportunity to receive continuing education credits by taking that survey as well. So a couple of announcements that we have here. Our Forum on Aging in rural Oregon is taking place May 15th through the 17th in Seaside. Registration is open now, and we're really looking forward to the event. So please check out our website and register for that. Nested within or kind of co-located with the Forum on Aging is our CAW Quality Workshop. And that is also occurring May 15th through the 17th in Seaside. Our next webinar is CAW Reimbursement Heuristic using the Medicare cost report to reveal opportunities. And that webinar will take place on May 11th at noon. And so please make sure to register for that if you haven't already. Really appreciate you being here today and really appreciate Carrie's great presentation. I think it gave us a lot to think about. And I will let you all go now and have a few minutes back in your day. Thank you.
Thank you, everyone.